We will now proceed to discuss and illustrate documentation of the first of these three components. First comes the documentation of the history component according to the CMS 1995 guidelines. In their guidelines, CMS describes three key components required for E&M documentation. In reality, there are four components required for E&M documentation: chief complaint, history, examination, and medical decision-making. The chief complaint is the medical reason for the encounter. The chief complaint does not have to be listed as the chief complaint. If there is no listed chief complaint, the first complaint listed in the HPI, or History of Present Illness, will be used by the auditor as the chief complaint for the encounter. There are three history sections: the history of present illness, the review of systems, and the past history, which consists of past medical history, family history, and social history. John Smith is a 58-year-old male with a cold for 3 weeks without fever. All evaluation and management, or E&M documentation, must have a chief complaint. In this case, the chief complaint is a cold. The HPI element 3 weeks is assigned to the element category duration. This HPI has one element and thereby meets the minimum requirement for the brief HPI. Again, in the 1995 guidelines, we have two levels of HPI element requirements: the brief, requiring a minimum of one element, and the extended, requiring 4 or more elements. The extended, requiring 4 elements, is a much more difficult HPI requirement to meet. In this next slide, we will examine an extended HPI. John Smith is a 58-year-old male with a cold. He has had a dry cough and right-sided chest pain for 3 weeks without fever. There must be a chief complaint. In this case, the chief complaint is cold. We have 4 HPI elements. The first is dry cough, assigned to the element category quality. The second element is right-sided, assigned to the element category location. The third element is 3 weeks, assigned to the element category duration. The fourth element is without fever, assigned to the element category associated signs and symptoms. We can see that we have 4 separate HPI elements, thereby meeting the requirements for an extended HPI. We are not ready to leave the HPI section yet. We've talked about the 2 different levels. There is the matter of how to identify HPI elements and assign them to element categories, which we will leave for the clinical examples section. But there is also a question of identifying which services require the minimum 1 element and which require at least 4 elements. We also have to know which services carry elective HPI element requirements. For that, we shall turn to the Code Blue coding tables. We are now going to take a look at the Code Blue coding inpatient and outpatient evaluation and management services table. In this section, we will discuss and exemplify the 1995 guidelines examination. In the 1995 guidelines, CMS gave us a limited amount of information about the examination requirements. They told us there were 4 levels of examination and gave us definitions for those 4 levels. Those levels were: problem-focused, a limited examination of the affected body area or organ system; expanded problem-focused, a limited examination of the affected body area or organ system and other symptomatic or related organ systems; detailed, an extended examination of the affected body area or areas and other symptomatic or related organ system or systems; comprehensive, a general multi-system examination or complete examination of a single organ system. CMS recognizes 12 organ systems: constitutional, eyes, ears, nose, mouth, and throat, cardiovascular, respiratory, gastrointestinal, genitourinary, musculoskeletal, skin, neurologic, psychiatric, and hematologic, lymphatic, immunologic. CMS recognizes 10 total body areas: head, neck, chest, abdomen, genitalia, back, and 4 extremities. In the 4 escalating levels of examination complexity we are going to encounter, we will see reference to both organ systems and to body areas. For simplicity and clarity, we are going to eliminate body areas from our definitions of the 4 levels of the 1995 examination. We have now covered the history and examination section. We will take a look at the medical decision-making documentation rules as laid out in the 1995 guidelines. CMS recognizes 4 different levels of medical decision-making complexity: straightforward complexity, low complexity, moderate complexity, and high complexity. The medical decision-making complexity is determined by 3 major components. The first is referred to as the diagnosis component, and for our purposes, really takes into account the number and type of presenting problems one has to consider. The second component is the data component. This takes into consideration the amount and complexity of medical testing, records, and degree of difficulty obtaining history and data. The third component is risk. This means the risk of complications, morbidity, and/or mortality associated with the presenting problems and your current or planned diagnostic procedures and treatments. These are the Code Blue coding medical decision-making tables. This is the diagnosis table. This is the data table. This is the risk table. This is the complexity calculator table, where we will bring the values we obtain from each of the other 3 tables to calculate a level of medical decision-making complexity. Before we look at how any of the individual tables work, let's run briefly through how all 3 tables work and how the complexity calculator table works. This is the diagnosis table. We assign points to each of the presenting problems, established or new, stable or unstable, then add up the total and put it in the lower right box. In this section, we will review clinical examples to reinforce our Code Blue coding medical decision-making first system. Mr. L is a 68-year-old male here for a persistent cough. He has had it for 2 months. It improves with alcohol. It disappears with sleep. He has lost 5 pounds over the last 2 months. He smokes cigarettes 2 packs per day for 43 years. He denies shortness of breath or chest pain. Meds none, no known drug allergies. Family history, no history of heart disease. Father dead at age 68, lung cancer. Mother alive and well, no SIBS. Married, 2 children, works at U.S. Post Office. Review of systems, see above. All other systems reviewed are negative. Blood pressure 150/78. Pulse 84, respirations are 18, weight 156, well appearing. Lips, teeth, gums normal. Lungs clear with normal breath sounds. Cardiovascular regular rate and rhythm without murmur. GI abdomen, no mass, no organomegaly. No cervical, supraclavicular, or axillary adenopathy. Neuro, deep tendon reflexes normal in lower extremities. Psych, mood and affect normal. 1. Persistent cough. 86 pack per year tobacco use history and 5-pound weight loss, not good news. We'll check chest x-ray, EKG, chem screen, CBC, CEA, and UA. I will await results to determine course of action, although I fear lung mass is most likely outcome requiring referral to pulmonary medicine. Our first stop is the diagnosis category. The patient has a new problem, persistent cough, and we are ordering a considerable workup. We will receive 4 points for a new problem with additional workup planned. On the coding table, we assign 4 points in the diagnosis column. Next, on to the risk category. This physician fears lung mass, the most likely outcome. On our risk table, in this case, the management of an illness that poses a threat to life or bodily function is the best choice unless or until the practitioner knows otherwise. Thank you for participating in our program. If you have any questions about the program or about Code Blue Coding, please visit our website at codebluecoding.com or email us at the email address at the bottom of this screen.